Hey guys, I hope you are well. So, in this session, we're going to be discussing pneumonia. Um, Pneumonia is one of the most common respiratory conditions that you will see in your hospital sessions, and it is important that we have a good understanding of how pneumonia occurs, the mechanism, the pathophysiology, in order for us to be able to understand the signs and symptoms and how they manifest. Okay, so let's just start with an understanding of pneumonia, right? So, firstly, when we think about pneumonia, we understand that it means inflammation. So, it's inflammation and exudation of fluid into the alveoli. That seems to be the standard definition. But we need to understand how this actually occurs and why it occurs. Okay, so I want you guys to think about it like this. So, pneumonia can be caused by, as we know, viruses, bacteria, fungi. Most commonly, it is caused by bacteria. Now, before we move on to classifying things rigidly and thinking about structures and, by hearting the different organisms, let's just focus on remembering it as a story. Okay. So, we have a patient, and this patient has inhaled some bacteria. Okay. And remember, with pneumonia, patients can acquire the infection through inhaling droplets that have been sneezed or coughed out, as well as through touching contaminated surfaces. That's an important thing to keep in mind. Right. So once the bacteria has been inhaled, there are different mechanisms in our respiratory tract to try and get rid of this bacteria. Now remember, this is a story. So as this bacteria is going down, you have this mucociliary escalator, right? So you're thinking of all of these um, ciliated cells that are lining our respiratory tract. Do you guys remember that? And these cilia, they are able to beat in a direction to move these pathogens, to move these organisms out of the respiratory tract. So we have the mucociliary escalator that gets rid of organisms on a daily basis. We have the mechanism of coughing. So you'll be coughing to get rid of anything that shouldn't be there. And the other thing is that we have macrophages. So you have your respiratory macrophages that are present in order to get rid of and to phagocytose foreign pathogens. Right. So what's really happening now is in pneumonia, these organisms, bacteria, viruses, or fungi, are able to bypass all of these mechanisms that are set up in the respiratory tract. And they are able to go down and they are able to go through your airways and they settle in the alveoli. And when they are in the alveoli, they are eliciting an inflammatory response. That is a key thing to remember in pneumonia, that it's this whole process is happening due to inflammation, right? So it's setting up an inflammatory response. And what happens during inflammation? And I want you guys to envision or to conceptualize this as you have alveoli in the lung, and the alveoli are surrounded by and are sort of being wrapped around with the capillaries, with the pulmonary capillaries, right? So now, during inflammation, you are having the capillaries becoming dilated and they are becoming increasingly permeable. So, what's happening is that the body is trying to get all of your immune cells, your white blood cells, whether it's the neutrophils or the lymphocytes, out of the capillaries and into the alveoli to be able to get rid of the bacteria that is settling there. But in the process of doing that, what's happening is that all of these inflammatory cells, the white blood cells, the neutrophils, right? So you have neutrophils, you've got some fibrin, and you may even have erythrocytes that are coming out of the blood vessel and they are in the alveoli. Now, what is this doing over a period of time? Over a period of time, you are having this fluid, these exudates, it's building up and it's building up. And what's going to happen? It's going to be the alveoli are going to become solid. That is why in pneumonia we talk about a consolidation, because that's what's happening. Now, before we move on to understanding the signs of consolidation, we need to follow up on the story. Okay, so the first stage we said is consolidation. The second stage is called red hepatization. But we know that hepa refers to the liver. So why are we bringing it up here? This is because in the second stage of pneumonia, the liver sort of has this red hyperemic appearance and it resembles that of the liver. But why? This is because your pulmonary capillaries are now congested. Remember, we said that they were dilated, they are now congested. And so the whole lung sort of has this red hyperemic appearance. Okay, the next thing that happens is gray hepatization. So I want you guys to think about it like this. So now the lung is no longer red, it sort of changes. Now remember, we're following the story. It changes and it becomes like this gray brownish color, even yellow. This is because you have purulent exudates that have built up in the lung, right? And also, what's happening is hemolysis. So we know that red blood cells, after a period of time, they break down, and when they break down and disintegrate, they have a brown appearance. I'm sure you guys have seen it when you guys have bled, that after a period of time the blood is no longer red, it looks brown. This is because of hemolysis of the erythrocytes. Okay, so that's what happens in that third stage where the lung changes from red hepatization to gray. This is because what's happening is that you're having this hemolysis that's happening. And also, the other thing to remember is that over a period of time, right, you had these exudates that were sitting in the alveoli. So you had this increased pressure in the alveoli and it compressed, it's sort of putting pressure and it's compressing the pulmonary capillaries. So as that inflammation is building up, and then in the last stage you now have resolution. So with resolution you just think of fibrinous inflammation that's happening, and this will bring us to something called um, a pleural friction rub, because you have inflammation that has even now spread to the pleura. And what happens is that when you have fibrin um, that's sort of like forming in the pleura, right, it can cause these pleural adhesions to form. So just keep that in mind as well. Okay, so now that we sort of have a picture of everything that has happened within the lung and the whole story, we're going to go to how do patients present clinically with pneumonia. Okay, so in terms of the signs and symptoms, so patients with pneumonia present with cough, and we already explained that this is one of the mechanisms for the body to get rid of mucus. Because remember that with pneumonia, patients generally have a productive cough, because we just said that the body is producing all of these exudates and you have mucus that is being produced, a lot of mucus. So the body is trying to push that up and you have coughing to get rid of it. So that's coughing. The next thing is dyspnea. The reason why the patient is dyspneic or has difficulty breathing, because it was similar to the story we mentioned with pulmonary edema. But here we have exudates that are building up in the alveoli. And obviously, if you have something that is sitting in the alveoli, you're not going to have ventilation and perfusion happening as normal. So that is why the work of breathing, the labor of breathing, becomes even more difficult, right? So the patient has shortness of breath or they've got dyspnea. This is an inflammatory reaction. You've got bacteria, so or viruses. So it could be that the patient is also developing pyrexia or a fever. Okay. And the next thing is that patients may have chest pain, pleuritic chest pain. So when this patient has got this bacteria that has infected the alveoli, the bacteria or viruses or fungi are very quickly able to spread to the hilum of the lung, and they are able to spread to the pleura. And when they do that, it causes inflammation of the pleura. And when the pleura are inflamed and they are rubbing against each other during respiration, it causes a pleural friction rub. And we say that the patient has pleurisy. So when the pleura are inflamed, we call it pleurisy, and it's a sharp. So pleuritic pain is a sharp pain. It's not like the pain we spoke about in MIs and angina, where it was sort of a dull, crushing pain. This is a sharp pain, and the thing to note here is that the pain occurs at rest and it gets worse with breathing and with coughing. So when the patient breathes in, the pain gets worse. And when the patient coughs, that's pleuritic pain. So it is associated with getting worse on coughing, getting worse with breathing. Sharp pain occurs at rest. That's pleuritic chest pain. We didn't cover it, therefore I'm explaining it now. So these are some of the symptoms that patients have. As we said, dyspnea, they've got chest pain, they've got fever, they've got cough. Patients that have pneumonia. And initially they just presented with your normal flu-like symptoms. There are many other symptoms, but these are the main things. So they may have fatigue and headaches and many muscle pain as well. So to focus on the clinical signs and symptoms now, in terms of clinically what's happening is that when you examine the patient, you might find that they are cyanosed. And as we just explained, it's the story that relates to dyspnea. So with peripheral cyanosis, we previously mentioned that it's due to reduced cardiac output, but in this case, it's not because of that. It's because there's a problem with ventilation and perfusion. That's where the problem is. The next thing is that on inspection, you will find that there's decreased rise of the chest on the affected side. So a patient has pneumonia, they've got consolidation, and there's decreased chest rise on the side with the consolidation. Okay. The next thing to remember, so that's an inspection, one thing to note, decreased chest rise on the side with the consolidation. The next thing that you should note is that when you do percussion, right, okay, just okay, yeah. Before we move on to percussion, on palpation, you'll find decreased chest expansion on the side with the consolidation or the affected side. And the other thing to note as well is that vocal tactile vocal fremitus is increased in that region where the consolidation is. Because remember now that the sound is passing through that consolidation before it hits your hand. So therefore it's increased. And then on percussion, there is dullness. Dullness to percussion in the region where the consolidation is. And the next thing to note is on auscultation. What do you expect to find on auscultation? The patient will have bruise, sorry, not bruise, bronchial breathing. Bronchial breathing. The reason why they have bronchial breathing is because of the consolidation. So, when air is passing through something hollow, um, yeah, so okay, let's just put it like this. Where do you find physiological bronchial breathing? Over the trachea. So it's sort of a similar concept when the air is sort of passing through regions where you've got consolidation. It sounds like this hollow blowing sound. That's the bronchial breathing that we're referring to. Patients may also have crackles. So remember, we talked a bit about crackles previously. So with crackles in pneumonia, the patient has got. Now remember that coarse crackles are produced by secretions in the alveoli, but fine and medium crackles are due to the opening and the closing of the small airways. So that's what they mean when they talk about fine, medium, and coarse crackles. Coarse crackles are due to air moving through secretions, but fine and medium crackles are due to the opening and the closing of the airway. Because remember, in expiration, the airways are closed, they are narrowed, so to speak, because in expiration we want the pressure within the chest to be increased greater than atmospheric pressure. So the airways are narrowed, and then during inspiration, when air comes in rapidly at that high pressure, it causes these small airways to sort of like snap open, and that is what produces the fine and the medium crackles. Okay, and then crackles only occur during inspiration. Therefore, we say that they are early inspiratory, they are pan inspiratory. So, how do you know? If it is early inspiratory, it means that the problem, meaning you're hearing it early in inspiration, the problem is within the small airways because air has to travel through the bronchial tree. So if you're hearing it early in inspiration, the air is still in the small airways. If you're hearing it late in inspiration, it means that the air is already in the alveoli. It's it's sort of that kind of an understanding. In very loose words. Okay, so you hear crackles, medium medium crackles. So it's late medium crackles that you will hear in patients that have got pneumonia. Um, but just to say crackles would be fine for now. Uh, and the other thing that the patient may have is a pleural friction rub. Okay, so just to summarize the clinical findings on inspection, we said that the patient may be in respiratory distress, they may have some cyanosis, dyspnea. You might find that the patient has tachycardia as well. And then they've got decreased rise of the chest on the affected side. On palpation, the key thing to note there is that there's decreased chest expansion on the affected side, and the patient has increased tactile vocal fremitus. On percussion, dullness to percussion. Okay, just to note that the apex beat and the trachea, they don't deviate in a case of pneumonia, so you don't need to mention anything about that. In auscultation, what happens in auscultation? We say the patient generally has bronchial breathing, they may have crackles, and they may have a pleural friction rub. So, this is what you find in pneumonia. These are the signs and symptoms. So, everything else, um, you can look for it, but this is the key things that you should be focusing and trying to find on examination after you've taken a history and you suspect that the patient might have a pneumonia. Okay, it's not to say that these are the only signs that may appear, but these are the most common signs that patients will have. And patients may not even have any of these signs if they've got bronchopneumonia. Because remember that with bronchopneumonia, on an X-ray, you'll see patchy involvement. With lobar pneumonia, you'll see involvement of an entire lobe. Okay, so that is when you will find the signs of consolidation. But with bronchopneumonia, you may not even find these things. So just to note. Um, okay, and just to sort of conclude the session, um, with organisms that cause pneumonia, right? So the bacteria that cause pneumonia, it's generally Streptococcus pneumonia that you should know, Staph aureus, and Haemophilus influenzae. Those are your main ones that cause pneumonia. Strep, staph, and Haemophilus influenzae. And then you also have atypical organisms. And this is things like chlamydia, chlamydia pneumophila, legionella. Um, yeah. So with chlamydia, you have legionella, you have mycoplasma. Those are atypical. It means that they don't respond to your normal antibiotic therapy. And then, in terms of hospital acquired pneumonia, your organisms are generally Pseudomonas aeruginosa and Klebsiella. Okay. And how would you treat the patient? What medication do you use? Besides your normal non pharmacological therapy, pharmacological treatment would be with amoxicillin generally. And in patients that are immunocompromised, you use amoxiclav, and that's to actually treat it. That's if it's bacterial. You don't use antibiotics if it's viral. um, yeah, so remember that, that's important. And then for to treat the pain, you can give an analgesic like paracetamol, and in some cases doctors may even prescribe aspirin because that's also an antipyretic. um, yeah, that's about it in terms of what you need to know. And then in terms of investigations that you could conduct, so after you do the clinical examination, you go to do the X-ray, and then with the X-ray, you're looking, as we spoke about it, signs of consolidation, patchy involvement, or lobar involvement, and You can also do blood tests. So with the blood test, you can do the full blood count as well. And then with bacteria, you generally find more neutrophils. With viruses, you find more lymphocytes. Yeah, so that's something to remember as well. And then you do a blood test generally to culture the organism so you can give specific treatment to the patient, especially if you suspect that they might have atypical organisms. Okay, so those are generally the basic investigations that you do in hospital environments, especially in the public sector. You don't really go further than doing X-rays and blood tests. Yeah. So I hope this sort of helps to give you guys a good understanding of what pneumonia is. And if you have any questions, you're